I don't want to leave this topic without at least briefly visiting something about antibiotic stewardship in this country and perhaps in the globe, and the overuse, perhaps the improper use of antibiotics. How does that impact the incidence and severity of C. diff? My sense is we're seeing more. I keep hearing we're using more antibiotics in animal husbandry and whatever. Are they related? Are people getting too much antibiotics over the counter, not over the counter, but over the phone, if you will, out in the community? Where does all this fit?
Yeah, so I think that the short answer is yes. We are.
Thank you, we can go home now.
We're using too many antibiotics, and we should use fewer, and that antibiotics do impact C. diff infection, and they seem to, kind of interestingly, impact it at every level. So if you look at hospitals that use a lot of antibiotics and compare them to hospitals that don't use a lot of antibiotics, the ones that use a lot of antibiotics have a lot more C. diff, even after adjusting for other factors. If you look at it at the ward level, so you look at one ward and another ward, adjust for all other factors, the ward that uses more antibiotics, there's going to be more C. diff on that ward. We even looked at it at the individual patient level. And if you look at patients in consecutive rooms, patients coming into rooms, at the room level, the amount of antibiotics received by the room actually seems to impact the next patient's risk for C. diff.
You do realize there are no more wards, right? There are units.
Floors then.
Floors, yes.
So this has sort of been likened to like the inverse of herd immunity. Most people are familiar with this concept for vaccines, but this is kind of the downside to that. So a lot of programs have been looked at to decrease rates of C. diff infection, and almost no matter how you try it, as long as you're trying something, you can get your rates down. But the cornerstone of all of these programs is antibiotic stewardship and using less antibiotics.
And you can decrease the rate of antibiotic-resistant C. diff as well, right? You don't start selecting out bad C. diff.
Well, there's negligible vancomycin resistance to C. diff, as we talked about. It's debatable whether there are some case reports of a higher MIC to metronidazole with C. diff. So it's not so much antibiotic resistance that's the problem, as that you've created an environment where there's just more C. diff around, more colonized patients shedding more C. diff spores in their stools by using more antibiotic.
Okay, well, let's talk about
what you suggested has actually been done with clindamycin control.
Okay.
And some C. diffs have got resistance to clindamycin. It's sort of the poster child for C. diff.
I mean, I remember, just to take us back, I remember the introduction of clindamycin. And the first thing we heard was clindamycin causes C. diff. It generates these.
Clindamycin
well,
colitis.
that's not what we heard, and then we figured it out.
Right.
But it was clindamycin, C. diff, pseudomembranous colitis, back to clindamycin.
But it's not surprising, that C. diff is such a big epidemic now, because we live in an antibiotic-rich society.
That's my
there's
point.
The recent data suggests that 50% of antibiotic use is unnecessary, which we already know, viral infections treated with antibiotics. And a second component to that, by the way, that we shouldn't forget is that when you use an antibiotic, don't use it forever, because much of the burden of antibiotics, much of the unnecessary use is actually prolonging courses beyond where they should be.
So let's run through a few bullet points here before we leave. First of all, you mentioned fewer antibiotics. The antibiotics are used for shorter courses. Is that for all community physicians? I mean, do you understand the position of a community physician who gets a call from a patient he knows or she knows well, says, I've got this, I want an antibiotic, and this community physician knows if you don't give it, it's going to call somebody else.
Well, but the answer should be, so one of the problems is spending time with your patient and actually explaining that to the patient. But I think that if you do that, and if the patient understands that they're not going to benefit from an antibiotic, they're not going to request it. If you decided to use an antibiotic, use the shortest effective dose. Don't use it forever. In the past, the thinking was, you prolong the antibiotic, only good things can happen because, it's more of a good thing. But now we know that's not necessarily the case.
Okay, and are there some antibiotics specifically that you want to cut back on? If you could talk to, and you are talking to, primary care physicians, you are talking to the physician community in America, what antibiotics would you warn them to avoid, if at all possible?
Well, it's hard to avoid one class of antibiotics, and all antibiotics have some benefit. As we heard from Daniel and others, fluoroquinolones, so Cipro, levofloxacin, some people call it vitamin L, as it became so prevalent in the community as well as hospitals. And we know that these are amongst the highest risk factors for C. diff, and there are also, as we learned recently, could be risky antibiotics in terms of the heart and some other risks such as the tendons and so forth. And
That's
so
with levofloxacin.
that's with levofloxacin, moxifloxacin as well. Avoiding using fluoroquinolones when they're not necessary, when you have an alternative that's just as effective, that the patient could be treated effectively, avoiding using fluoroquinolones would probably be your first step. Third generation cephalosporins are also a big risk factors. Not that many are being used in the community, more so in the hospital, but this would be another risk group. Clindamycin we already talked about. There are still some, mostly dentists and gynecologists and obstetricians, at least from my experience, that use a lot of clindamycin where we know that there are treatment alternatives that are less risky. That would be another group.